Hey there, Careblazer. Welcome back. I'm so excited to be here. Today, I am interviewing a pharmacist. He's been a pharmacist for over 25 years, and he's taking the time out of his day to answer all of your questions. A couple months ago, inside of my Facebook group, I asked, what questions do you have about dementia and medications? And many of you submitted your questions. So today I sat down with him and asked him all of your questions, and he answered them all. I'm very excited to share this interview with you. Chris not only is a pharmacist and spends most of his time behind the scenes, he's also the owner of a company called Home Scottsdale, and his company provides in-home caregiving help assistance for people who need it. Okay, Careblazer, I hope you enjoy the interview. What are some of the common dementia medications out there that people may have heard about or may be interested in learning about?
Okay, so as for medications that are specifically for dementia, there are two classes.
Okay.
One of them is called an acetylcholinesterase inhibitor.
Okay.
That class has the medications Aricept, another name is donepezil. A couple other ones are galantamine, rivastigmine. Those names would be Razidine and Exelon, and those are the most common in that class. And then the other one is an NMDA antagonist, and the only medication in that class is memetine, or another name is Namenda.
Okay.
And what the acetylcholine, what they do is they increase the transmitter acetylcholine in the brain, and that is the transmitter that is involved in making memories and cognitive function. And the memetine, what it does is it decreases the overstimulation of the cells, which can cause cell death.
How does somebody get on one of these medications? Like, what determines what class of medication they get to?
Okay, person with dementia, they'll usually start showing some symptoms at home, and usually it's going to be either a loved one or somebody close to them is going to notice some changes, and then they'll usually make an appointment with their doctor. And then what the doctor can do is they'll do a small, it's called like a mini cog.
Yeah.
Are you familiar with that? So it's just a very quick test, takes maybe 5-10 minutes in the office. They can get some real baseline information, whether they possibly need some other some more intense testing, and then based on that, they'll typically, what they will start off with, depending on where they are, if it's mild to moderate, they will usually start them off on that first class, the ones with the Aricept, the acetylcholinesterase inhibitors.
Okay.
Those are indicated for mild to moderate stage dementia.
Okay.
The memetine is typically saved for moderate to severe.
Got it. So kind of depending on the severity of the dementia, that kind of predicts what class of medication they're going to get on.
Correct.
Now, is it common for somebody who maybe started out mild and was on that first class of medications, once they progressed to being more moderate or severe, that they would get added on to like a Namenda, so that they would be on both classes at once?
Yes, that's true. Okay. And in fact, they now there's a medication called Namzaric. That is a combination of donepezil and the memetine.
Okay.
So they put it into one tablet for convenience of dosing.
Okay, got it. So it's really the severity, though, that's guiding which medication that the doctor is prescribing initially.
Right, and part of the thinking of that is that as dementia progresses, when you have the death of those neurons, when those cells die, they release some of the contents of their intercellular fluid into that space between the neurons.
Okay.
And some of those chemicals that were released affect what's called the glutamate pathway.
Okay.
And that is another excitatory pathway in the brain. And when that pathway is excited, it causes what they call excitotoxicity. So it's overstimulation of those nerve cells.
Okay.
And that overstimulation can cause further damage to other healthy cells.
Okay.
And that's where the memetine comes in. It helps block that pathway for the excitotoxicity.
Okay. Now, can you break down, because there's a lot of confusion, a lot of questions about what exactly do any of these medications do? Do they slow down the disease? Do they start to reverse the disease? Are they just dealing with symptoms? I've kind of heard it all, and I'm wondering if you can kind of provide some insight for the Careblazers out there.
Sure. Okay, so the acetylcholinesterase inhibitors, the first one that they usually that they try you on. So with that one, those are more improving the symptoms. They're not slowing down. Whereas the memetine possibly has some neuroprotective properties because it is preventing further damage.
Okay.
So that one is thought to maybe actually help slow the progression.
Okay.
Whereas the acetylcholinesterase inhibitors are just they're helping the symptoms.
Got it. Yeah. I worked with a really great geriatrician back in the past, and I worked in a clinic where we would be providing that initial diagnosis of dementia. Like families would bring their loved ones in and they were like, something's off, like what's going on? Is this normal? Is something happening? So we would be offering that initial diagnosis of dementia a lot of times. And for the most part, it was kind of in those early mild stages. And so Aricept or donepezil was kind of the go-to medication that they were often prescribed. And the geriatrician would often describe it as, it's kind of like, let's say you're taking Tylenol for arthritis, you still have arthritis, that arthritis is still there, but the Tylenol helps with the symptoms. That's kind of what the Aricept or donepezil is doing. Like the disease is still there, it's still happening, but it kind of helps with the symptoms. Does that make sense? Would you agree with that kind of description?
Yes.
Okay.
Yes. Yeah, that's a good way of putting it.
Okay. For somebody whose loved one was just recently prescribed one of these medications, how do they know if they're working or not? Like, would they notice anything in their loved one? Is it different for everybody based on like who their loved one is? Like, are there any signs or symptoms that they would be able to identify to say that this is actually working or not?
That's a good question.
Okay.
I know just speaking from experience with clients, some have had some very short-term memory loss. They're very early stage,
Okay.
where they may lose their train of thought, or they can still remember things that happened a long time ago.
Yeah.
But things within, we went and saw a movie last week or something like that, they may not remember, didn't we go see a movie?
Mm-hmm.
Those types of things. What they might see is that going on the medication, now these medications don't work immediately. They can take up 2 to 4 weeks to start working.
Okay.
Okay, so that's one thing to remember.
Got it.
Once they've been on it a month or so, they may go to another movie and they may actually remember more specific details about what they did, where they went. They may not remember. Or another example, they went out to dinner, they don't remember where they went.
Okay.
Well, they may actually making those connections and forming new memories.
Got it. Okay. So it does take a while for these medications to kick in. So if your loved one was recently prescribed one of these medications, give it at least 2 to 4 weeks for it to actually kick into effect and for you to notice any difference. And some of the difference that you may notice would be just filling in more details, like your loved one being able to fill in a bit more details.
Mm-hmm.
Yeah.
Yeah, and sometimes maybe you may notice them a little more alert. Possibly,
okay.
Because it's increasing the acetylcholine, that neurotransmitter. That is one of the main ones that makes your brain function.
Okay.
And so you just might notice some a little more alerts. Just maybe more. Just more. I know it's hard to describe, but more there.
Yeah, more there, more
right.
alert.
Exactly.
Wonderful. Okay.
Mm-hmm.
Now, if for some reason somebody has been on one of these medications for several months and their family has not noticed any difference whatsoever, is it generally recommended that they just stay on these medications because there might be something that it's doing underneath that just isn't coming across outwardly, or is it okay to just kind of stop these medications?
So when I've talked to neurologists that have prescribed the medications, what they prefer to do is to get them on the medication as soon as that they know that there's some sort of deficit. Keep them on the medications for, if they can, as long as, sometimes they have to be stopped because of side effects, things like that.
Okay.
When they when the families say we don't, because they're, some of these medications can be very expensive.
Yes.
And that can be a barrier, for people continuing them. What the doctors will maybe recommend is, like, instead of stopping the medication, why don't we decrease the dose for a couple weeks?
Okay.
Because as those medications take a couple weeks to build up, they take this time for them to decrease in the system also. So it's going to take maybe a few weeks, and then let them stay at this new dose, and then see where they are cognitively. If they notice, you might notice, hey, you know what, maybe those were doing something, because maybe their memories, they're seeing a little difference.
Okay.
Maybe a little more despondent, those types of things. Their affect may change a little bit.
Yeah.
But instead of stopping them totally, that way they're not totally not getting the benefit or totally having it stopped in their system.
Sure.
They've still got some, but it may decrease the level enough where it's not therapeutic anymore.
Okay.
And so, hey, we are seeing a change. Well, we can bump it back up so they haven't lost it all.
So it's feedback, right? Like, you go on a taper, and based on how your loved one may or may not change with that reduction, that's feedback. Oh, maybe that medication was doing something I didn't realize, because they seem like they just took a hit and got worse.
Right.
And so we can bump back up, or, maybe it really wasn't doing that much at all. But it sounds like it wouldn't be so wise for Careblazers to just stop the medication altogether right away without consulting whoever prescribed that medication in the first place.
Yeah, right. Yeah, I would always recommend that you always have a discussion with your healthcare provider about whether to stop the medications.
Okay.
And another thing is, at that point, if they're just on the Aricept, we'll say, they bring it down, they notice that change, and they bring it back up, it may be time to maybe start to introduce maybe Namenda into the system then at that time.
Yeah, that's a good point too. So maybe there's a medication that they've been on forever, like the Aricept, and all of a sudden maybe it doesn't seem to be doing much. That might be time to add a new one. Okay.
Right. Another thing is that when loved ones see a change, a really rapid change in the patient that that has dementia, another thing to look at is maybe other medications that they're on.
Yeah.
Possibly. Because a lot of times there's anxiety that is associated with it, things like that. When you introduce another medication into that formula, there's going to be side effects, and depending on the type of medication, and there are some that are better than others to use with in those types of situations. A real sudden change in behavior, I would really start to look at it. Maybe it's not disease, but more medication related.
Yes, absolutely. Any sudden quick change is always worth investigating. I always get suspicious of delirium, because anything can be setting that off. That's always a good recommendation.
Right, and I think a lot of it depends on the type of dementia. So when you have Lewy Body, because that you have the peaks, right? It fluctuates.
So speaking of that, are these medications that you mentioned, are those good for all types of dementias, or are they only good for certain types of dementias?
So the main types of dementia that I typically we talk about, or you see a lot of literature on, is going to be like Alzheimer's. That's the main one. Okay, then you have what's called vascular dementia, and that is usually going to be a blood flow issue, and that could be due to head trauma. It could be due to stroke. It could be due to diabetes, high cholesterol, blood pressure. All those attributing factors. And then you have Lewy Body dementia, and so just for example, these medications, like in a vascular dementia, somebody that's had a stroke, they may have some benefit, but it's about treating the underlying cause, which is blood pressure, cholesterol, diabetes, those types of things. You want to make sure you're treating the blood pressure, with keeping the blood pressure at a good level, keeping cholesterol levels within a healthy range, and keeping the blood sugar, in a healthy range also.
Absolutely. So it sounds like for the different medications, a lot of them were really made with Alzheimer's in mind, but they may also be helpful for some other dementias. But the key is you want to find out if you know the type of dementia your loved one has, like the treatment the healthcare professionals should be trying to treat the underlying cause. So for example, something like vascular dementia is going to be much better approached by, managing those vascular conditions. That's going to be the primary approach over maybe some of these medications.
Right.
Okay. And then, of course, you could have multiple types of dementia, so then there might be kind of a mixed kind of treatment approach where you could be on some of these medications plus trying to control all the vascular risk factors and so on. Okay.
And then I think when you get into that, it's about managing side effects.
Yes. Let's talk about side effects.
Okay.
What are some of the common side effects of these medications?
So with the acetylcholinesterase inhibitors, most common complaint is nausea, loss of appetite, headache, insomnia, sometimes abnormal dreams. And it's just because these medications are they're stimulating nerve conduction in the brain, so it's making it fire more. It's what you want with with dementia. So you want that brain working, you want it working more efficiently. With the Namenda, you can get diarrhea as well, constipation sometimes, headache, sometimes difficulty sleeping, and sometimes some depression with it. And that's because it's suppressing an excitatory pathway, so you're kind of slowing down the brain in that sense. And so it's just finding a good balance between those two and managing that.
Somebody wrote in and asked, if someone doesn't seem to be benefiting from the medications, does that mean they're too far along in the disease process? Like, is it possible that somebody would be in the severe dementia range and then none of these medications would really be helpful? Or could you go to some of that second class, like Namenda type medication, and still be worth a try?
I think it would be worth a try in those cases, and I think it's probably both of them. It's just because if you start treatment at a certain level, once you put these medications into their body, you may help retain that level more and to help keep them from declining further. So you may not notice any improvement, but you may be prolonging that decline or
Now, is it possible, because a lot of times people with dementia have difficulty swallowing, or they don't want to take medications, or there's all those other kind of challenges. Are these medications crushable?
So there are different dosage forms that are available. Like Aricept. The original ones, you could crush those. They were an extended release. Now they've come out with an Aricept 23. That one, I will need to do I would need to check on that one. There's Namenda. There's Namenda, now there's Namenda XR, which is a capsule. With the capsule, they don't recommend you chew them up or crush them, but from what I've read, you can open those and put them in applesauce. But when you do that, they have to eat the entire amount that you put it in, so you don't want to put it in a large amount. They also do make an extended release. Not extended release, but they a liquid. They make a liquid also. So that could be an alternate too.
And I apologize if we already mentioned this in the class of medications, but there's the Exelon patch, correct?
There is Exelon patch, yes.
And so that might also be an option if somebody's having problems with swallowing or is really hesitant to take medications. Is that something that
Yes, the Exelon, that's going to be the acetylcholinesterase class.
In that first class.
Right, yes, it's applied once a day. So you have to change it. So every day. But that would be another alternative. Yes.
So some of these medications may be crushable, others not. Again, check with the prescriber, because it really depends on the dose and whether or not it's extended release and the form that it's in.
Right, and especially when you pick them up from the pharmacy, especially if these are whenever you get a new medication, make sure that you talk to the pharmacist about them. By law, they're required to cancel you on new medications. And I know there are some. You go into some pharmacies and they are so busy. I mean, you should be at least offered the counseling. If and you can decline it if you want. I always recommend, especially with these types of medications, that you do talk to the pharmacist about them, or and your doctor before they're when they're prescribed. And that's a question that should, can come up. Can these be crushed?
Yeah, that's a really great recommendation. So easy, so simple, often overlooked. When you're picking up your loved one's medications at the pharmacy, and they should be asking you, do you want to speak to a pharmacist, or a pharmacist should be coming up to you, absolutely ask them these questions. It doesn't require another doctor's visit, doesn't require hanging on the phone on hold forever to get a hold of your loved one's doctor. Take advantage of that resource. So yeah, thank you for bringing that up. That's really great.
Absolutely.
Yeah. Is there a better time of day to take these dementia medications? Like for some, like I know there are medications that maybe it causes sleepiness, so it's good to take at nighttime. Do any of these dementia medications work that way, where it might be better to take at a specific time of day?
So the medications like Aricept, typically the most common side effect is the nausea, and loss of appetite. Those are usually recommended to take at bedtime. Okay. That way, once you take it, if you're going to have any of those side effects, you're asleep, so you don't notice it as much. Now, sometimes people do have, they do cause insomnia, or have really make you have abnormal dreams that are that just some people aren't comfortable with. It's okay to switch those medications from evening to morning. The most important thing about them is that they're taken on a daily basis.
Okay.
And if you can, try to take them at the same time.
Okay.
Namenda and the Aricept, those they can be taken without regards to meals, so with or without food.
Okay.
But it just depends on like side effect management.
Okay.
But if you can, same time each day.
So same time each day, take them consistently. They're not as needed medications.
Right.
And then again, like so much in dementia, however their loved one responds, like whatever side effects they're having, you might need to make an adjustment, but it doesn't necessarily, mornings no better than night. It just kind of whatever side effects they might be experiencing, try to choose the time of day that makes better sense.
Right. Yeah, I think for some reason, and some people, these do cause drowsiness, so nighttime would be best. If you take it and they seem to be more alert, I would switch it to the morning.
Okay. Now, do these medications, do they pretty much help long term throughout the disease progression, or at some point do they kind of lose their effectiveness? Like, does the body build up a tolerance to them?
It's not that they build up a tolerance. I think it just gets to the point where the brain gets to just a state where the medications they're affecting different parts of the brain, where it's going to affect like the verbal centers.
Got it.
Those types, different parts of the brain where you're not going to see the benefit from them.
Okay.
So you can see benefits from a month. I mean, it could last a month all the way up to maybe 5 years.
Okay.
I mean, I've had clients that have been on medications for 2 years, have been doing well, and then they kind of start. You see that eventual that deterioration.
Is it fair to say that because these medications don't actually prevent or necessarily like stop the disease from progressing, that at some point when the disease progresses beyond a certain point, the medication can only do so much?
Yeah, I think
that's a decent way to. Okay.
Yes. Yeah.
Okay. Now, there is a lot of hype right now in the news and articles and everything, and one of the Careblazers wrote in and wanted to know, do you have any information on CBD oil to help with dementia and anxiety?
Okay. I spent a lot of time looking into this.
Okay. Thank you.
Right, and it seems like a lot of the information that's out there is it's from the UK, because they actually have some of these medications on the market there.
Okay.
They have some so you've got CBD and you've got THC, right? So the THC is more of the psychoactive part of the marijuana plant.
Yes.
The CBD it's more the anti-inflammatory side of it. So what I've read is that there are some positive benefits to both.
Okay.
Now, a lot of this is still in animal studies.
Yeah.
Not a lot of human studies yet, and if they have, it's been very limited testing.
Okay.
So I'll talk about both of them.
Okay.
Okay. On the THC side, it seems like where there seems to be some benefit is maybe in the aggressiveness and some of the agitation.
Okay.
It kind of has like a mellowing effect.
Okay.
Okay. And also in appetite stimulation,
Yes.
as you always hear this about what marijuana, those two things about it, just kind of evens out and with the appetite stimulation. So if there's some issues with with weight loss, which can be an issue,
Oh yeah.
there's that side that it could help. On the CBD side, that is going to be more of an anti-inflammatory side, so it actually may have some neuroprotective properties to it. Now you don't get the psychoactive, you don't get the euphoria, which is associated with the THC side, but you might get some anti-inflammatory effects.
Okay.
Now, it's all, I was reading, in fact, one of these articles I was reading was it's called Molecule. It's a chemistry magazine. I don't know if you're, yeah.
Those are usually over my head.
Yeah, very technical magazine. So I spent a lot of time on this one article because it was talking about different phytonutrients that not only with these two, but it was talking about curcumin,
Yes.
talking about resveratrol, those types of things. So it's like more just a natural side of this, and there is some promise to it,
Okay.
but just more studies are needed.
Okay. All right.
But from what I understand from the CBD, there you don't get the psychoactive. It's something you might talk to your doctor about. I mean, I know you can order a lot of this online. Some states it's legal, some states it's not. I know California is a lot more progressive, I think, in these types of things. But I think it's something definitely worth looking into.
Yeah, something that maybe shouldn't be written off right away, something to consider. And I think that it's just taking a while for the medical community to figure out,
Right.
to do the necessary studies, gather the necessary information, what are the side effects or risks, and
Right.
before they can really put their final stamp on it. But I do talk to a lot of caregivers who find the CBD oil really helpful for them.
And that's kind of what I've heard anecdotally also.
Yeah.
Now, another thing about when you look at pharmaceuticals, most pharmaceuticals have some sort of natural origin. And so, and what they do is they look at the chemical that occurs naturally, and then they take it and they can manipulate the molecule, and make it more effective or whatever. So, I mean, I think you're gonna see probably some of these things are gonna show. They're gonna become standard treatment eventually. I think.
I am with you. I think that they're going to be more and more common, and we're going to see it more and more.
Yeah.
Yeah. So, anxiety is oftentimes an issue for people with dementia, and this is often a source of stress for caregivers. So, but there's also a lot of hesitation from the medical community and from providers to prescribe anxiety medications for people with dementia, right? High fall risk, increased impaired cognition. Are there any safe anxiety medications for older adults, specifically older adults with dementia?
Safe medications. I would maybe say safer medications.
Okay.
So I don't know if you're familiar. It's called the Beers list.
Yes.
Okay, that's a list of I think
Yes.
70 of drugs that are not recommended in the aging population just based on side effects. It's about the fall risk.
Yes.
Okay, most of those anxiety medications that you're familiar with, Ativan, diazepam, Valium, Klonopin or clonazepam, those medications which are generally used for anxiety, which work really well, typically are not the best for your dementia patients because they decrease cognitive function. That's how the medications work. They decrease the brain's activity, especially like in the emotional part of the brain. It shuts it down.
Yeah.
So that's how you decrease the anxiety. There's another class of medications, the serotonin, the selective serotonin reuptake, the SSRIs. Those are medications like Zoloft, that's sertraline, Lexapro, citalopram, Paxil, paroxetine, those types of things. Those don't have, Zoloft and Lexapro, those are probably like they have less of the sedative effects like the benzodiazepines. So those are probably a better choice.
Okay. They don't maybe work as quickly or as
Right.
rapidly as the other ones, which I think is a lot of times what, the families are hoping for, but they are much safer.
So, I would think it would be fair to say that the benzodiazepines, they are okay to use as a bridge to when the other medications start to work. So you're still looking at 3 to 4 weeks with the SSRIs. If you are, if your loved one needs it, obviously there is it's not to say you can't use them, but you want to use them at the minimum effective dose and as little as possible if you can, because when they are habit forming, the body can become dependent on them. And I've seen over the course of 25 years, I've seen people who have been on these medications a long time.
Yes.
And it's difficult to get off of them.
Yes. I've come across patients who have been on them for decades, and then all of a sudden they have a new provider, and the new provider's like, you can't really be on this medication, and that really puts them in a tight spot,
Absolutely.
So.
And I think what you're seeing now, you're seeing a lot of crackdown by the FDA on the use of, especially like opioids.
Yes.
The benzos and those, they're all falling in those same class. There's another class of sleeping medication called the Z drugs. They're not exactly benzodiazepines, but they work similarly.
Okay.
Like Zolpidem, Sonata, Lunesta, those ones, they work very well, but they can be just as habit forming. So especially when you get all these things in combination together, that's when you can start having a lot of issues.
Yeah. I'll give a really quick story. I actually work with a patient who was on a benzo, and when I first met him, he looked like he was pretty cognitively impaired. And with some time with his healthcare provider, he was weaned off that benzo. We have amazing discussions now. He remembers our sessions from session to session. It's like he has just come alive. Like, it really does impair cognition. But what I'm hearing is that these medications exist for a reason. They can be helpful. They can be used as a bridge. When you do use them, low dose possible. You got to be careful because they're habit forming, can lead to falls, impair cognition. And in the end, I always preach when it comes to dementia and any behavior like symptom, anxiety, agitation, whatever it is, like a non-behavioral approach should always be attempted first. A non-pharmacological approach should always be attempted first before you jump to let's get a medicine to help with this. Let's try to figure out if our approach can be changed to reduce their anxiety, if we can comfort and reassure them. And then if it's needed, by all means, go talk to your provider. But it's generally not your first line option. And it does come with some significant side effects.
Absolutely. And another thing we should talk about is when you talk about non-pharmacological intervention, your over-the-counter medications are considered medications.
Yes.
And I tell you, one of the big go-tos for people is Benadryl.
Diphenhydramine.
Absolutely. One of the medications that, those are antihistamines, and they have what's called anticholinergic activity. Well, anticholinergic is working against your medicines like Aricept because they're working on the cholinergic part of the brain.
Yes.
And so you are working against, and these all cross the blood-brain barrier, and they get in there and they work against the medications that you're trying to.
Yes.
So, when you see PM, that is generally it's Benadryl that's included. If you see ZQuil, that's Benadryl. There's another one out there, it's called Unisom. It's called doxylamine. It's a very strong antihistamine too, and that's usually what they put in NyQuil.
Yeah.
So, you got to really be. When you go pick up, you're usually, if you're at a drugstore picking it up. Even at a grocery store, there's usually a pharmacy there. If you're concerned, stop by there. They'll be glad to talk. I'd say 80% of the counseling I do, if it's non-prescription stuff for people, it's about over-the-counter stuff all the time.
Absolutely, Take advantage of the resources that are available to you very easily, like through the pharmacy. So.
And it doesn't cost you anything. So, it's...
Absolutely.
Yeah.
And you're already there trying to pick something up anyway. Might as well make it. It'll actually save you time by picking up something that's more likely to be good than having to take a run back and realizing that maybe you just gave your loved one something that is not so helpful.
Right.
So, Well, Chris, I really appreciate your time in answering all these questions. It was really helpful, really informative. I appreciate it.
Well, thank you for having me. No, I am a big fan of the Careblazers website, and I recommend it to our clients. If they have any questions, I think you're a really great resource.
Oh, thank you so much. Now, if there's anybody maybe in the Arizona area who is thinking about hiring care for their loved one with dementia, like where could they go to find out more about you and about the services?
So we have a website. It's rightathome.net.
Okay.
It'd be /Scottsdale.
Okay.
They can also go to just the Right at Home and put in their zip code, and then that will bring up. It'll bring, because we have different offices in the area. It'll bring up their office according to where their zip code is.
Okay.
We cover all of Scottsdale, Fountain Hills, and Paradise Valley.
Okay.
If you're concerned about a loved one that may need some help, we can come out. We can do just a real quick assessment. There's no charge on it. Just come out and just sit down and if there's possibly the needs that your loved one might need, we can be glad to come and sit down, no charge, and see if it's something we can help you with.
That's really nice, really great deal. All right, well, Careblazers, I hope you enjoyed this interview. I think Chris gave a lot of helpful information to the questions that you submitted. I hope you find them helpful. I'll be back next week with another video. Bye.